Neuroorthopedic Department, Humanity Research Hospital in Italy, with vast, more than 30 years in experience in pediatric orthopedic. We are very excited to hear his topic from today, and I would be happy to share this event with my colleagues and Dr. Albara Atwarji, assistant professor and consultant pediatric orthopedic and vice dean for medical college Tabuk University, and consultant pediatric orthopedic at SGH Riyadh. Dr. Bara, delighted to have you today as well.
Thank you.
And my friend, Dr. Amr Batouti, is consultant pediatric orthopedic, Saudi General Hospital in Cairo. Dr. Amr.
Thank you. Welcome you to Dr. Khalid and Dr. Bara, and of course, Professor Dr. Nicola.
Thank you very much. And so just some of the housekeeping for this webinar that would ask the audience if they have any question during the presentation, please, in the question and answer tab below, type your question, and we will answer the question orderly. So without further ado, I would leave the mic to Professor Portinero for his presentation. Dr. Portinero.
Thank you very much. Thank you very much. I mean, it's actually a great honor and a great pleasure to be invited by this not very far away world. And I got a lot of friends in Egypt, all doctors, orthopedic surgeon, and they always very friendly, and I enjoy the invitation very much. So thank you. I think I'm gonna start this chapter, and I put the Epiphysiodesis as a title on purpose, because in fact, it's not an epiphysiodesis. I mean, we're talking of epiphysiodesis when it's something permanent. And nowadays, we like to use biology, not to have something permanent, but to have something we can modulate with growth or with correction or recurrency of the deformity. So we actually, in Italy, we call epiphysiodesis, which is a temporary epiphysiodesis. And, so the concept is two different kind of operation. We used to have a big problem 20 years ago when even with blunt staples, when we had to decide when to do an epiphysiodesis, because we have to be very accurate determining the timing and, according to the child growth remaining. And it was very difficult. Actually, it was very easy to make a mistake. Now, these new devices are helping us in kind of determining, with all the table that I'm going to show you, determining the right moment and the timing to do the operation, but we still have a plan B. So if something goes wrong, we may be able to, recorrect, or if there is an overgrowth or an undergrowth, we can modulate our treatment. I think, let me see if we go into the second slide. Why is not going? Now, I think one of the most important thing, which I've been studying when I was doing my PhD in Oxford, and I did study the different growth plate around the acetabulum and the triradiate cartilage, is the growth plate. We did study if we could make the growth plate grow for longer time, to have an epiphysiodiatasis, so lengthening the growing cartilage, which went all right, but we didn't have enough. We did a study on animals, and we didn't have enough samples to conclude anything. But there's, at the 4th week of life, still the growth plate, or yet the growth plate is ready to grow. And there are two fundamental moments: the aligned cartilage production, and then the substitution of it by bone tissue. The second important thing for all the surgery we're doing now is the growth plate between the primary and the secondary ossification nuclei, where it's the place where we are allowed to grow, but in fact is the place where, as a surgeon, we are allowed to intervene to do minimally invasive surgery on children and prevent further deformity in adults' life. So the growth plate, is made by different cells layers with a quiescent area, a proliferative area, hypertrophic area, and we go into chondroblast expansion, extracellular matrix reduce, degenerative phase where we got an increased volume of the cells, and chondroblast degenerate to produce extracellular component as hyaluronic acid, etc. And then there is the vascularization phase and the ossification phase. This is very important because when all these 5 phases are finished, we cannot act minimally invasive anymore because there's no space. So again, some images. This is some sample I had from Oxford University done by myself. And this is the front of ossification with bone marrow and primary bone growing with invasion of vessels. And this is very important because most of the problem we have with the growth plate is when this ossification phase goes from the primary to the secondary or epiphyseal ossification center. And this makes the growth plate stop growing, or every pathology that lies inside different layers of the growth plate may determine a lack of growth, an asymmetry of growth, or a deficient growth. It's very important to have in mind that while we're putting staple and we're doing minimally invasive surgery around the knee, everybody knows that the knee, the tibial and the femoral growth plate are responsible of most of the growth of the bone and the growth of the lower limb in total. Now, classification of leg length discrepancy has been one of the main topics by different authors in many years. In general, we got a problem of the growth plate in total, and we can have a bilateral or unilateral deficiency. So we can have a ending up with short stature if bilateral, or a leg length discrepancy if it's unilateral. If we got a partial growth arrest or growth problem, then we end up having varus or valgus. Sometimes we don't have problems. It's just that, you know, the growth plate doesn't grow as fast as the contralateral, or the growth plate inside, like in Blount disease, it goes in a different speed from medial to lateral side. The classification could be made on length or on etiology. So we can have an hypometria or an hypermetria, which is sometimes, if it's not associated with different conditions, it's difficult to determine which one is the long one or which one is the short one. So is the short or is the long, which is quite difficult sometimes in absence of determinant pathologies. Sorry. So otherwise we can have congenital condition, developmental causes, or acquired condition, which may determine a lack of growth of the growth plate. This is a fast classification of hypometria. We can have asymmetrical neuropathies, trauma, growth plates, diseases, which in fact, if you think, includes most of the osteochondral dysplasia, Calvert-Perthes disease, Blount disease. So most of the children, most of the children problem are around the growth plate, from proximal focal femoral deficiency to medial fibrous dysplasia of the tibia. They all may include a growth plate problem. So being able to treat growth plate problems with minimally invasive surgery and costless treatment with in-stay in hospital for, we discharging the patient in 2 hours. So, and they go home They got bed rest for a day, and then they're free to do whatever they want. The hypermedia, again, soft tissue overgrowth, like in neurofibromatosis, all the vascular, all lymphatic syndromes, Becker's-Whiteman syndrome, Proteus syndrome, or different other pathologies of the growth plate, as we all know, post-traumatic, hemihypertrophy, septic arthritis, fractures, etc. I think one of the most difficult thing is, in fact, to decide when to act on the patient. Now, we got some help from history. We got something that I use very frequently, the Grölich and Pyle Atlas. So we asked the radiology to give us the bone age, because in some syndromes or in some systemic disease, we may have different bone age from, you know, the age of the patient. So it's very important to understand. And in fact, one of my questions when I see a patient with a leg length discrepancy or deformity is, are you the tallest, the middle, or the smallest in your classroom? Which is nothing scientific, but it gives you an idea if he's a big 13-year-old, if he's a small 13-year-old, or whatever age, or if he's in the mean. And this is something that gives me straight away an idea of where to put the patient in terms of timing. We got all the predictors of skeletal residual growth according to age, and those they very useful. And but sometimes if you're in a hurry in a clinical busy outpatients, it's something that you have to leave for afterwards when you're planning the decision to make or when to make the surgery. Mosley graph is a predictor of length. It's very interesting, but it's sometimes difficult to interpret. And sometimes I find myself, you know, getting busy on putting the lines and find the numbers where I can, you know, where, how much is there to grow. And then we got the Paley's multiplier, which is telling us how long the patient is going to grow, or the leg length discrepancy is going to grow according to age and time. I like the Shapiro's development patterns because it gives you an idea of what may happen. And this is from a geometrical point of view. You need to point to have a line. So I'm always taking an X-ray of the patient, standard upright, sorry, not upright, standing position for the lower limb. And then I take another X-ray a year later before I make my decision. This is for leg length discrepancy, of course, not for varus and valgus. So if I got to point and then I got the Shapiro's lines, I can tell that if type 1, the leg length is gonna become more different with time. I gotta hope that they're not gonna be impaired, but there's not gonna be a major growth in the last part of the growing bit. And I know in type 3 that there's not gonna be leg length discrepancy increasing after a while. And all the other curves are very, very associated with different, probably syndromic and systemic pathologies. The indication of treatment. The indication of treatment is in a general point of view, and in the literature is not how can I say, is not completely shared by the all different surgeon. I think, you know, for less than 1 centimeter is quite difficult to offer a child to undergo surgery for at least twice, putting the plates and removing the plates. So sometime I decide if the child is especially near growth maturity, I decide to do nothing, or I decide to put an orthesis if the mother, as you say, as you know very well, is worried. We did a study where leg length discrepancy of 1 centimeter doesn't change the gait analysis of the patient. So you got a plantar flexion knee extension moment, which is very similar to the one you have in normals. So the pes equinus and flex knee is so mild that doesn't act in the power you're gonna use and produce during walk. We do normally the epiphysiodesis if it's more than 1 centimeter, and a leg length discrepancy, of course, should be not too much. I put 8 centimeter because there was a paper that said, oh, we do shortening of the long leg with 8 centimeters difference, which is this, again, you have to ask the parents how tall they are, because if you got a 2 meters father and 1.8 meters mother, you may lose 8 centimeters, but it's a lot. So you're probably going to choose something different. And at the end of the presentation, you're going to see that this difference in length is now going to be possible to be equalized, with an internal growing system described by my friend Drew Paley. And I've asked his permission to show you some very interesting slides on a new device. We have acute shortening, which is near to skeletal maturity, but is something that is, you can't do for more than 2 or 3 centimeters and is still wasting length in total. We can have acute lengthening with an intramedullary nailing, but has got the bone quality is not very good. You got neurovascular risk, and it's something if I can, I try to avoid and to do it before. And this is a lesson I give to the pediatrician. If you got any doubt, send them when they're young, so we can do something before you have to do at bone maturity. Of course, we're not talking about big hemimelia where you got 5-6 centimeters when the child is 5, because the indication is completely different. The indication is probably to have an X-fix at 5 or 12, or do all-in-ones at 12. And of course, the external fixator is the optimal choice to lengthen. And if you have to control different deformity like bowing, like Varus valgus, associated deformity with the above or below bone. So if you got problem with the femur or with the tibia together, or the tibia in hemimelia and the foot, then probably X-fix is going to be the best choice. Now we go to Varus valgus. I'm not going to do the definition because I think I'm offending you, because you probably know it better than I do. But we got Varus valgus different etiological causes, from big difficult cases like femoral hemimelia or tibial hemimelia, to simply developmental knock knees or bow leg with tibia vara, which are, more than 20 degrees of, or 2 standard deviation, We can have trauma where we got an overgrowth or partial physical arrest, and we can have systemic or syndromic pathologies associated with growth, with growth plate growth. And then we got other million causes, as you know, like growth plate injury, rheumatoid arthritis, osteogenesis imperfecta, and I'm not going to go on just elencating all the different causes. We got this calculation that you can do, has been described by all different authors, and we got the degrees of normality, they ranging not largely, but still, as it happens in medicine, you don't have a fixed angle or a fixed Varus valgus deformity where you can definitely say, I have to correct it. And as I will say to later on, I think experience, after you have done all the study and after all you have done your calculation, is something that you have to put in count before you make a decision. So in general, the distal femur, if it's more than 90 degrees, is my indication to be done, that needs to be done something like in proximal tibia 85. Distal femur, leg length discrepancy, lateral angle 85 degrees. and proximal tibia measured more than 90 degrees. Of course, when you're taking an X-ray, a standing X-ray of the lower limbs, you have to take in account of two big things. One is the ligamentous laxity, where it can change or increase your deviation in varus or valgus. The other very important thing is the malalignment. We all know that the children has got a intratorsion of the femur, and the extratorsion, physiological extratorsion of the tibia starts before the extratorsion of the femur. So sometimes if you got malalignment, you misjudge a varus or a valgus. So it's very important that the X-ray should be taken in a standard manner. And this is what is calculated, what it was presented in the slide before on a proper graph. And I'm very pleased if you want to keep my slides, and but this is quite a well-known calculation. Very important is the clinical examination. Clinical examination is firstly done by the pediatrician, who's going to send you the patient to be examined from an orthopedic point of view. So physical examination is lying and standing. Standing, we see the line between the two iliac crests, and we have to check if the patient has, of course, got another associated illness. And you see the position of the pelvis, which is always tilted. And sometimes the patient comes to see you because they think he's got scoliosis. And you probably have seen this in all your practice. Then on a lying position, you can measure the distance between the iliac spine to the knee and the ankle, and this is the real leg length discrepancy, or you can measure from the umbilic, which is the subjective, so what the patient feels to be the difference in his leg's length. Then you can measure the distance, from the iliac spine, medial malleolus. We can have the Galeazzi sign, so to see and detect clinically if you got a tibia which is shorter or a femur which is shorter. My personal view is that, and is what I'm trying to honestly tell the patient, is that if you basically do this measurement in a clinical practice, your error, both alpha and beta errors, are huge. And you see, we're talking about millimeters. So if my idea is that I do something over 1 centimeter, if my error is 3-4 millimeters, it changes completely my indication to do surgery or not to do surgery. So I'm pretty well more happy to measure the real difference of the two bones on plain X-ray, which the error has been described to be less than 3 millimeter, so is fairly acceptable. So this is the concept I was giving you before. The patella should be zenith patella, so pointing at the ceiling. And I don't normally take an X-ray with a rise because, of course, if I don't know yet the difference in length, I run the risk of putting a rise and doing my indication of surgery on the rise I put on under the foot, which it may be very wrong. Now, I think surgical technique here we could discuss all night. Sorry. And surgical technique has been described by the definitive Epiphysiodesis in 32. And one of my best authors, because I think he was a genius, was Professor Blount, that thought that putting some devices to stop growth was the idea. And that was it, in fact. Everything came from 1949. So we had different technique, but the staple were the first idea of temporary epiphysiodesis or epiphysiorisis, followed by Green and Anderson. And then we went back on definitive epiphysiodesis, which is which is very difficult for the surgeon, as I said before. And then in 2007, my friend Steven presented in Orlando those new plates at the TAG-JAN course for pediatric orthopedic surgery. And I was there and I thought it was a great idea. And I been the first one to use them in Italy for both axial and lateral and deformity of varus valgus. And I didn't use, but I'm going to tell you about this. I'm using some screws for a temporary epiphysiodesis of the proximal femur in subluxating hip, both in DDH and in cerebral palsy. So surgical technique, I'm not going to go through this. I just put it for the sake of having a nice, very colored image. And so you can all wake up and say, very interesting. But of course, it's not done by me. And this is epiphysiodesis. So you put a piece of bone, you flip it, and you stop the lateral growth, medial and lateral growth of a growth plate, stopping the middle part. You leave the middle part intact, but it is not going to be able to grow anymore. That's the big risk, because you're under risk of fracturing the femur. You're under risk of having a deformity of the condyles, especially. And so it's not an ideal technique. This is the Blount technique, which was very good. Blount had put it straight. The longest part, the longitudinal part of the staple should be parallel to the axis of the bone, which I don't think it makes a major difference unless it's too inclined and oblique. Then it may give you a torsional problem, which has been discussed and described by some authors, but not proved yet. And this is Green and Anderson thought that because the problem the Blount has that was that the staple, one staple was not strong enough to keep the growth plate closed. So Green and Anderson described it to put three staples were more and much safer than to put only one. And if you see, this is start to be a big operation because the incision need to be long. The wound is long. It's super periosteal, but still it was quite a compliant thing for the patient. Then this is the Bowen and Johnson definitive epiphysiodesis, and this is screw epiphysiodesis described by Metazer, which he was very successful, was percutaneous, and he was very happy. But still, the problem of closing a physis too early, and or having the screw breaking. They were just the major problem that he had during this surgery. And then it was calculated the fulcrum. The fulcrum is important because it tells you where the growth plate is blocked, so the major blocking power of the plates, and on the 8 plates, we're having 30 degrees movement. So my idea, and I'll tell you later on, is how to put the plates, or we can have it during the discussion, how to put the plates and the screw, if to put them horizontal, or if to put them parallel to the growth plate, or to put them completely open at 30 and 30 degrees, which is 60 degrees opening. Now, 8 plates are very handy. I think the learning curve is quite fast, very few principles. You can use them at all ages. In fact, the only problem you need skeletal growth remaining, because otherwise there's no point of using the plates. You can use them in all BMI, all growth plates. We've been doing them in multiple exostosis, sick physis, as in physis with systemic pathology associated like rickets. We did in multiple exostosis, and they work very well. all planes deformity can be corrected, which is yes. And again, as I said before, rotational deformity are more complicated because you need to calculate it. How is the inclination you have to put obliquely the plates? And to be honest, I don't have any experience on this, and there's very few publication with evidence-based medicine. Now, again, general consideration is they reported in a lot of paper in the literature, and I think, you know, angular deformity, this is the degrees you should consider to do the operation. And by Stevens, the growth remaining and the growth of the proximal tibia and distal femur are probably 6 centimeters per year. This has got a bias because there's a growth speed which changes with ages of the patient. So you got a growth speed at 14 or 13-year-old, which is less than the growth speed when you have a child which is 10. So all these calculations should be, you know, referred to the age of the patient, BMI, and we calculated, you know, more in a more radical and specific way, instead of just saying 1 centimeter per year or 0.6 centimeter per year. And this is the calculation sometimes. This is one of the best drawing I could do that you see underneath on the slides. I'm a terrible drawer. And, but basically is, you know, where is the fulcrum? So where's the maximum power you can have to stop the growth plate? Now, my personal view is that you should put the screw parallel if you got a deformity, because then you're letting the two screw open up, but the fulcrum of the correction is at the maximum lateral or medial part of the growth plate, letting the part which is not blocked growing faster. So if you're putting the two screws open, they are already locked. So there's no movement around the screw. So if you put the screw open, you're going to have less growth plate able to grow. And so the correction is going to be slightly slow, and is going to be, the growth plate is not going to be parallel anymore to the joint surface, but it's going to be slightly oblique. So you may run the risk when you're removing the plates to have a recurrency. So this is what's happening. While, sorry, I go back to the slides before. If you put, if you have to do an epiphysiodesis for leg length discrepancy, you should do the opposite thinking. Because you have to block both sides of the growth plate, then you have to insert the screw opened up and locked, so the growth plate is completely and fully blocked. And in this case, I'm using a longer screw. I don't think it matters much the size of the plate. While if I have to do an epiphysiodesis, I'm gonna use normally shorter screw to leave, you know, the other part of the growth plate which is not blocked to grow faster. This is a concept we can discuss because it's not easily understandable. I mean, it took me quite a long time to understand what I was doing in theater. We do basically nearly percutaneous approach. We check under the image intensifier the line of the growth plate. On the AP, especially on the femur, we stay slightly high, and on the tibia, we stay in the center of the growth plate. We insert percutaneously the plate on the wire. We check under image intensifier. I'm not using light palette to put 3 different wires and cannulated screw, only because using cannulated screw, it's something that run more risk to break the screw when you remove them, especially if they made in titanium. And the scar is very small, terrible stitches, of course, when the stitches are terrible, you should always blame your assistant. It's never my fault. Only because I never stitch up, but it doesn't matter. And so this is the technique that you all know. You check, you see that we stay slightly high on the AP of the femur, and the idea that it should be axial to the long axis of the bone. It doesn't matter if you see on the lateral, which is a not beautiful lateral, but if it's slightly high, it doesn't matter, because what's matter is the tip of the screw. That's my belief. So if the tip of the screw is in the right place and is not perforating the growth plate, it's a satisfactory position. And this is just how it works on my favorite topic, which is the growth plate. Now, because we all know the orthopedic surgeon, we all very greedy on seeing images of X-ray pre-post and patient pre-post. And we're not very keen on basic science. I just put it down some cases. So just to show you that, you know, it's not me, but it's not my assistant, but the 8-plate really do work very well. Leg length discrepancy with genus valgum. And let me say, introducing this case, you can have multiple deformity. So as in this case, you can have varus valgus plus leg length discrepancy. And with the 8 plates, it's being such a small operation, you can correct both together. So what we did correction of the valgus, because anytime you correct the varus of the valgus, you're gaining length. We put the plates, and then after a year, when we had straight leg, we put the plates on the other side only, and we do an epiphysiodesis, and we had good results because we had leg length equality in a year. And as you see, I put it on purpose because the patient were very happy, but unfortunately one of the screw broke. And this is a post-op, straight post-op X-ray, where the line of the femur and the tibia are fine, are well aligned, but the screw remains on X-ray as a as a mark of your incapacity. I'm just joking, of course. And this is another case. So if there's a deformity, I put the screw parallel so they can open up. And the fulcrum, if you see my arrow, I hope, and the fulcrum is basically outside here. So all the remaining part of the growth plate, including this, is able to grow. And so the only part that doesn't grow is very, very, very medial or lateral, according to the deformity you have to correct. And this allows you to have a faster correction and a faster correction. These two screws for me are slightly longer if I do an IMI, and they of the right length if I do an epiphysiodesis. And this, it's another case is for genus valgum with a tibia, which was the major deformity. So we calculated the angle, and we decided to put the plates on top of the periosteum as we do, and on the medial side of the tibia. Now, this is valgus and of the femur and tibia vara in hypophosphatemic rickets. She's a lovely girl, and she started having pain, difficult to walk, and she was kind of socially embarrassed. So we started to correct with a very simple operation. The mother was very happy because they offered her big surgery as osteotomy and thing. And I said, look, be patient. We're trying to do with the plates with a mini operation. If it doesn't work, I'll do an osteotomy when she's older. And this is the follow-up at 6 months, and the mother was kissing me and crying and being very happy because the results, if you see this slide, are quite good. And this is at 1 year follow-up. We haven't finished the treatment yet, but look, she now looks pretty normal, unless the bowing of the femur, which is not correctable with the plates. And now I just wanted, if I got the 5 more minutes, I'm going to go through all the most interesting patterns with his vascular problem or lymphatic problem. She's a lovely girl who has a very sad story because she was a little tiny toddler when she came to me, and she's got a lymphatic disease. As you can see, the leg was 3 times the other side, and we put it some plates, and we calculated the differences. And we put it the plates. When we had to remove the plate, she went from Varus to valgus. And, you know, at the end of the day, the results were very good. We had to keep changing because she was going, you know, the leg length was fine. So they were equal. But then she had a thrombosis of a vertebral artery. So she was paralyzed, and we lost the follow-up. Sorry. The other big interesting chapter is all the vascular syndrome, like Klippel-Trenaunay-Weber and all the rest. So the problem here is deciding when, because as you can imagine, you do when they 8-year-old because they got 3 centimeters, and you shorten the leg. The patient is happy, but due to the fast metabolism and increased metabolism, the risk of needing to, or the need to redo the operation is quite high because of the original vascular problem. Here, as in the lymphatic problem, we've got an extra problem with is the surgery. They bleed a lot, and sometime, well, we never gave them any blood transfusion, but you know, we do with tourniquet. We're very careful when we have to catheter to do the hemostasis, but we have to keep them at least 1 night for survey of the blood loss. And this is a case. Discrepancy, we put the screw where they 2 parallel for my taste, and of course, because I don't like it, again, probably one of my assistants has done the operation and not myself, because I'm perfect. I'm just teasing you all, of course. And this is another case, minor vascular problem, leg length discrepancy. We did both at distal femur and proximal tibial arthrodesis, and at the end the difference was nearly reached. Sorry, the leg length discrepancy was nearly 0, but he underwent neurosurgery for thrombosis, and so we lost the follow-up. And this is a case with multiple exostosis and angiodysplasia, and the child has had a valgus knee with multiple exostosis. We corrected the valgus both on the tibia and on the femur, and it went very well. Satisfactory, the correction of the axis of the lower limb, and this, when we put the plates, follow up. The problem, we went to hypercorrection because the patient didn't come back. So we had to explain to the parents that, you know, the follow-up is very important, not every 3 days, but at least every 4 or 6 months, I'm going to see them, especially if they got vascular problem. So we had this hypercorrection, which we needed to put the plates again, to move the plates and put them on the lateral side. And that's the results. Now, I'm going to present this internal device for lengthening designed by my friend Drew Paley, which I think in my mind is going to be the future for leg length discrepancy more than 3 centimeters. And basically it's a plate where you do the osteotomy, and then you got a magnetic device, which is lengthening the plates, and it works very well. and you can reach 4 to 5 centimeters of diaphysial or metaphysial lengthening. And the patient, of course, can walk on it, and the compliance of the patient is higher compared to an X-fix. And this is just to show you this new thing, which I think is going to be, you know, probably my best new toy for my remaining 10 years of career. Thank you very much for listening. I hope it was not too boring, and we went through the basics, and probably you know more than I do, but I enjoyed it very much. And again, thank you very much for the invitation.
Well, thank you. It was very, very nice, very thoroughly discussed the topic, and it has a lot of tricks for you guys, all the attendee, and all of us for doing such surgery. And I would urge you all the participant and attendee, if you have any question, please type it in the question and answer. In the meanwhile, I would ask from Dr. Batouti or Dr. Tawagri to join us here as well, to have some thoughts about the A plate. Well, let's start with the as a technique, as regarding the A plate. I want to hear your thoughts, guys, as regarding the length of the screw, the angle where you put the screw. That Dr. Nicola emphasized that it make a difference as regarding the angle. Well, how do you put the screws in the metaphysis and the epiphysis? Would be your thoughts as well. So let's start with Dr. Batouti.
Thank you, Dr. Khaled. I would like first to thank Dr. Bortinaro for his presentation. It was very informative, and actually he added new concepts for me, starting from the term of epiphysiodesis, not only epiphysiodesis. You're talking about the technique of applying this plate. I prefer, of course, to do it central in both AB and lateral. As per precision of the screws, I try as much as possible to be parallel for the physial line. But if it's a little convergent or a little divergent, I think it's accepted in the matter of we don't subject the child for many manipulation in entry of the K wires or the guide wires. Also, I restrict the length of the screw to half the length of the epiphysis. And in some epiphyses like distal femur, where it's not regular, I do the calculation by the width or the diameter of the shaft.
Okay. Oh, nice. So, yeah, are you done?
Please repeat again.
Go ahead. Sorry to interrupt.
I have asked Dr. Bortinaro from his experience, if I may ask.
So Dr. Batouti is asking you about your thought.
Sorry, I didn't hear. I'm here. I'm not asleep yet.
Okay.
No, I'm just asking from your experience questions that you rise from the presentation. First, you dealt with patients with dysplasia from different kinds. So what is your experience with the Blount disease? In what age do you apply it, and how beneficial or what benefits does we gain from epiphysiodesis in Blount disease?
Now, Blount disease is one of the most interesting things because they correct very well. I normally put, when I'm sure it's a Blount, I'm putting the plate, the little plate, when around 5. They correct by one year and a half. The problem is that sometimes, because there's a pathology of the growth plate, as I said at the beginning of the presentation, sometimes they go back. So we got 35, 37% of recurrency in Blount disease. but the recommendation is that sometime, I had a case which I remember very well, and now he became a friend of mine because he's 21, and he was too heavy. So he was loading the growth plate, which was already damaged. So we put the plate, we removed the plate, we put it again the plate, we removed the plate, and then I had to do an osteotomy. So in blount disease, I normally wait till 5. So when we're sure that it's a blount, and then when the deformity is at least 15 degrees of Varus.
Okay. A second question is about what you said before about patients who got overcorrection or sometimes the first deformity due to lack of follow-up. What is the proper management for them? If a patient, was starting by a Varus deformity and due to lack of follow-up, he returned with a valgus deformity. What's your approach?
Well, this is the problem is the system. When these things happen, is the system. In Italy, everything is done by the parents. So if I tell the parents come back in a month or in 6 months or in a year, sometimes they do get lost, they forget, the child is better. And then they come back and say, look, I think I'm not very happy. The leg look funny. And I said, look, I was waiting for you a year ago. What's happened? I had family problem. So we don't have basically to say that we don't have an hospital system calling back the patient. So giving them a call and say, look, you have to come back because it's needed. A follow-up is needed. But the good thing about the A plates that, you talk to the parents very clearly, very nicely, and you say, look, we can't leave a leg like this. You've seen the valgus becoming a Varus, and the Varus was important. So it was not a Varus that could be left alone. So we just decided to basically swap the plates from lateral to medial. And, of course, it went well and the leg was straight. The problem is if you are nearly at the end of growth, and if something like this happens and you don't have enough growth remaining, then it's very difficult to deal because you can put the plates, but you're probably not going to reach, normal angle as a correction.
And my last question, when we deal with a big child with a big physis, does you always apply only one plate or you can apply 2 plates? Because there are some new designs that have a quadrangular structure with 4 screws. Have you ever tried these before? And if they have any advantage on the single plate?
I tell you, honestly, we had to do a child, and he had vitamin D resistant rickets, and we put the 2 screw, and the bone was so fragile that it became a mess. This is something that honestly I'm gonna tell the world because it happens. So if you got a fragile bone, the risk is having only 2 screws is that you make lose the locking or lose the grip. So sometime if I got a fragile bone or patient are obese or big boys, then I use the quadrupod, as you said, which is easy to fix. And of course, the operation becomes larger. You need a larger approach. You have to go more distal and more proximal, but it fixes very well and is very stable. I don't think I use the quadrants on a normal child unless he's got bone problem as a metabolic or syndromic or something that maybe I don't know. So I'm worried that the 2 screw will not fit.
Okay, and the question to Dr. Khaled, what's your opinion about applying only one plate or applying a double plate on the same side? Have you ever done this?
So you are saying to use 2 plates when you are having a big kid, chubby with a high BMI. So
Yes,
this,
exactly.
yeah. So this is one of the paper being published with Dr. Herzenberg and their team at the Children Orthopedic that discussed the incidence of the broken screws, and they concluded that when you are having a high BMI with the Blount disease, these are the higher risk for having a broken screws. So at that time, they recommended using the quadruple plate. For me, I didn't use it, but I would like to hear Dr. Al-Bara to hear his opinion as regarding using the quadruple plates, or even here to from you all of you, if you still use the Metazoa screw, does it still have a play nowadays, or the 8 plate have replaced all the Metazoa and the stables? Dr. Ba?
Thank you, Dr. Khalid, for invitation, and I would like to thanks Prof. Bortinaro for this nice presentation, and always stick to the basic. It was very nice, as we had in our college, just to stick to the basics always. And just I have one question for Dr. Bortinaro. What about the timing of removing the correction of varus or valgus? Are you recommend the hyper correction, and how many degree you recommend for that? Because some literature is they are advising that for overcorrection, and some of the researcher they said no, we have very good result for this. Actually, there is a lot of dilemma about this one. The second thing for Dr. Khalid, you asked me about the screw, using of the screw. Actually, I think no more screw using in the first and third countries, world countries.
Okay.
Always, and I think we have now shifted to the 8-plate screws, and sometimes we use staples. And actually, there is a good result, better result with correction with the double stapling, double, not a single staple. The result is better than the single stapling, even if it's center, but still the patient has some rotation after correction. What do you think, Dr. Prof. Nicola, about this, about the correction with the single stapling? Is there any remaining rotation, especially rotation, after the whole period of correction? And thank you for all of you.
Thank you. Very interesting. Now, the first question you asked is, shall I overcorrect or not? Well, from a biological point of view, there's something called the hungry growth plate syndrome, which is in epiphysiodesis. You run the risk that the growth plate, which is still happy and willing to grow, will have a phase where you have an overgrowth in terms of speed. So I like to, I'm not very in a hurry to remove the plates. I normally leave an extra 1-2 centimeter in leg length discrepancy and 2 degrees in deformities, because I've had cases where in a normal child with developmental leg length discrepancy, we had not to put the plate back, but we had an overgrowth of the long, what it was the long leg, and so we kind of lost a couple of 2 or 3 millimeter. I think, 2 or 3 millimeter, if we have shared the concept that one human being over 4 has got leg length discrepancy of a certain degree. So I'm not willing to attack any child unless he's more than 1 centimeter. So if he's overgrowing and we got a remaining leg length discrepancy of 1, 2, 3 millimeter, I don't think it really matters on the spine and on anything else. And the second question, I think I didn't understand about the rotation, what you were asking. I'm very sorry.
Dr. Varus. I didn't get as well the question, but so let's move with the. I think that he's not around, but so one of the things that for the A plate, when you are removing the A plate, is the concept of the sleepy plate, where when you are planning to have this plate for a longer time, and you are concerned about the overcorrection. So at that time, you will remove the screw from the metaphysis, leaving the plate inside the patient with the screw in the epiphysis. By this, you can have a period of time where the kid can grow for a while. And if you are concerned about any rebound, you can reapply the metaphyseal screw. And there is a lot of emphasis about it. So I want to hear your thoughts about this idea. Have you tried it, Professor Nicola?
Oh yeah, now I'm using this quite often, this technique to leave one screw in the epiphysis and the plate. So
Okay.
I basically do a percutaneous removal, which is the patient goes back home in 2 hours, which is very good for him. And I normally do this, especially in vascular and lymphatic problem, because the risk of overgrowing again is very high. So I regularly do it, when they ate, or according to the leg length discrepancy or the deformity, I do around 8, leave, reach the correction, overcorrect a little bit, take one screw out and leave the plate and the epiphyseal screw in. And we nearly do this routinely, especially in Sturge-Weber or Klippel-Trinoni-Weber, when you got fistula, venous arterial fistula.
Dr.
And the question answer windows, I see most of the question are asking about continuous medical education. So I wish that someone will give them a final answer. But there is a question I want to repeat to Dr. Portinaro, is asking about if you are giving the choice for the parents in cases of limb length discrepancy, whether to shorten the long one or to lengthen the short one, or you always follow the protocols that were shown in the presentation?
No, you're right. Thank you very much for specifying. I mean, the presentation, this is a kind of subject that you can talk 10 hours if we go into hemimilias or proximal femoral deficiency. I always discuss the patient with the parents, sorry, not with the patient, or sometimes with the patient, if he's 10, 12, they start understanding what's happening is their legs. So I always say, look, you can lose 2 centimeters. If it's 3, 4, 5, I always offer them the choice of having a lengthening. I think the future is going to be with this new plate done by Dror, Palais, that this is going to be very good because, you do an osteotomy, you can put like a LIS. Do you know the LIS plates? So the one that it is percutaneous insertion of the plate. You do a mini access to do the osteotomy. You put percutaneously the screw, and then you lengthen the short limb. So you're not going to leave. We're not going to talk now about dwarfisms, but we're going to just to talk about leg length discrepancy. With that plate, you can lengthen 3 centimeters, which is, if it's a small stature family, it should be probably the gold standard indication.
Okay, another question about the idea of guided growth and epiphysiodesis, and how is it successful in other bones or other joints in the body? Has you tried them in any experience in the upper limb, or like distal humerus or stuff like this, or distal tibia?
I've done it for a valgus in a distal tibia and went very well. They do work because, the interesting thing, if I may be slightly funny now, is that it doesn't depend from orthopedic surgeon. It depends from biology. You know, we are the problem, but biology works very well. So I did in distal humerus, I did in medial and lateral malleoli after fracture, and they went very well. But they went very well because of the growth plate, not because of the surgeon.
Mhm.
I mean, we did 7 distal femur. We did 4 medial malleoli, and we did for a Varus, we did 1, I think 1 or 2 lateral malleoli.
So, Dr. Nicola, during your presentation, you mentioned something about using it in the hip. Can you emphasize on this?
Oh, I thought it was going to be a surprise if you want to invite me again.
Uh,
I'm not going to tell you. No,
okay.
I'm joking. No, it's very simple. The idea is that the greater trochanter grows up to 7-year-old, more or less. Then if you got a subluxating hip, both in a 3-year-old for a DDH, or especially on a spastic hip, then if you put a little percutaneous screw and you block the growth of the proximal epiphysis of the femur, but the graded trochanter still grow, you got a varising effect. So you delay, or probably you stop, or we got cases in which we improve femoral head coverage with Reimer index. So the idea is you ending up with a slightly shorter neck, but the hip doesn't need an operation as a Varus, the rotation osteotomy, and a pelvic osteotomy. And we published on JPO the largest series with 10 years follow-up. And I did it with John Davis from Sacramento. And it was a nice study because I'm now, the inclusion criteria are very strict. So you need to have an acetabular index less than 30 degrees. You need to have a Reimer index less than 30%, well, about 30-40%, so less than 50%. And the hip should be stable. And we do the screw and nothing else. We don't do soft tissue. And the idea is to do it when you're very little. So when you're 4, 5, 6, because otherwise it doesn't make any sense. Because the growth plate would not give you the optimizing, varising effect.
Okay. And Dr. Batuti, I want to ask you about the, do you use as well the cannulated screw for your 8 plates, or use the solid screws?
I usually prefer the cannulated screws. It gives me a chance to use the guide wires first to take the proper position without much manipulation, especially with the epiphysis and epiphyseal plate. And I didn't face until now any implant failure problem with them.
Now, my point is, when you are planning to take the screws out with the, as Dr. Nicola mentioned as well, that because of these are titanium, and when you have the torque, getting it out most of the time, even I counsel my patient that it will break. So do you have any issue with taking it out or breaking the screws?
Well, thank you, Dr. Khalid, for raising this issue, because here in Egypt, you know, about the, money is a problem sometimes with the implants. That's why we sometimes prefer using stainless steel implants in favor of titanium. Okay. Most of my cases that I used here in Egypt were from stainless steel, and I didn't face any problem or complication for using them. And I think they had the similar results at the end. So I didn't face any implant failure with them.
Okay. So Dr. Bara, he's around? So what about you, Dr. Nicola? Do you still use?
I agree with Amra entirely. I mean, it's always a money problem. I think Egypt is a country like Italy, so we don't have the money that they got in the States. So using stainless steel implants, even if cannulated or not, it's probably safer because stainless steel screw doesn't break.
Yeah.
And sometimes when we were using the titanium, you know, to prevent breaking, I normally put the screwdriver, I lock it in a little bit for half a twist, so the bone gets slackened and less tight to the screw, and then I undo the screw. Like we used to do in trauma 15 years ago, 20 years ago. One lock in and then lock out.
Yeah. So because of this issue with the titanium screws and the cannulation, so there's a technique that been described in the literature that they put the wires in the two holes and use the cannulated screw just as a tap and just for the tip of the screw. And after this, you can take the wire off and use the solid screw. Because most of the time when I'm trying to take, like if I'm having like an 8 plates or like a 4 plates in a distal femur, I would counsel my patient that maybe I will leave 4 broken ends of the screws in the distal bone, and sometimes it's a little bit not very happy patient that they leave metal inside their kids. Anyhow, so
Dr. Khalid, does you use a drill bit before introducing your screws, or you apply it directly on the bone over the guide wire?
no,
You use a drilling bit first?
Yeah, I use a drill.
Okay. Use a cannulated screw, you can use only the drill bit to mark the direction, and then you can remove all and use a normal screw, right? You don't have to use a cannulated screw from the beginning.
Yeah, so I use the cannulated screw just to open the flutes or the serration, that it can help me when I'm taking the wire. It would be more easier not to skive when I'm putting the solid screw, non-cannulated screw. So it's a written technique. Sometimes it works, sometimes it doesn't.
The problem is, I think the problem is that there are few or some very small change between the diameter of the cannulated screw and the solid screws. That's why I don't like to revision one from another.
Yeah.
It make the
Yeah, good point as well. Okay, and so what would be the youngest age for the 8 plate, Dr. Nicola?
You know, as we said in Blount, I think 5 year would be fine. There are some congenital. I had a case of a young lady that was 3-year-old with a asymmetrical deformity of the tibia in valgus, and then I put the plate in, you know, when she was 3.
Okay.
And where I'm using the plate, but still this is another issue, I'm using the plates in a 3-4 year old in when they got a fixed flexion deformity in arthrogryposis. So then we did probably 10-15 cases. So you don't touch the muscle, you don't do any big osteotomy, you just straighten the leg with the plate. I had a case which I actually have seen him on last Monday, and he's a patient I'm following up in the last 4 or 5 years. He had a bilateral club foot treated by Ponseti method, and then I put it bilateral anterior plating at the knee, and now he's got a perfectly straight leg. He's playing football, and the foot are good, and they're very happy. And of course, 5 years ago, the mother especially was very skeptical. So she said, "Oh, but look, I don't see anything. You know, the knee is still bent." I said, "Look, you have to take it easy, because this is not a big surgery. It's not something that you wake up and the knee is straight. but see, trust me, and it went very well. So in neurological condition, I'm using quite a lot of them, but this is for another talk.
Okay. Okay.
My question for Dr. Khalid.
Yeah.
Have you faced any complication like snapping syndrome with especially the lateral plate of the distal femur?
That's a very good question, because it all depends on the technique. So most of the time, you have to be sure that there is no much soft tissue below the plate. And one other thing that when the plate in my hand, I use contouring. Sometimes I contour the plate to match the bone. I am very precise in having no much of the shank of the screw prominent, and a lot of times when I use the alternate tightening. So I tighten the one screw above and one screw below, doing it sequentially. At that time, I would have both screws seated in the plate well. But with everything, like I'm saying, sometimes you can have some of the irritation of the head of the screw on the iliotibial band, and can cause the snapping that you are mentioning.
Thank you, Dr. Khalid.
Okay, so it was very fruitful discussion and very elaborative talk from Dr. Nicola. Very delighted to have you, and very delighted to have Dr. Amr and Dr. Tawarji as well. And I would thank you all for your time, and because it's very delighted to share knowledge and hear the thoughts from different parts of the world, and hopefully that we can meet in real life, in a real meeting, rather than sticking our faces to the Zoom. I think that I'm dreaming about the day that I will disinstall the Zoom application on my computer and my phone. But hopefully that we would pray that everything would go well. And thank you for the attendee for your time, and see you all. Be safe.
Thank you very much. Thank you very much. I was delighted, and you're all invited in Italy after the vaccine. When we leave the vaccine, you may come and stay anytime. Anytime.
Yeah, hopefully, yes. Okay.
Ciao.
Thank you very much. Thank you.
Ciao, ciao.
Goodbye. Goodbye, everyone, and thank you for this discussion.
Thank you.